We're very excited to be presenting this program, HIV and Aging, Improving Health and Wellness, as part of the Elder Initiative's Conversation Series, which are our educational forums for the community. We have had, for the past couple of months, had a community advisory committee that has been putting together today's program, and also planning ways for the Elder Initiative to be able to plan a series of programming over the next 6 months, covering a range of issues related to HIV and aging. So we're very excited. This is the first program in that series starting today. So the past 4 years, going back to 2012, the LGBT Elder Initiative has hosted a program on HIV and aging each year. It's actually the first program that the Elder Initiative ever put on for the community, and have really been exploring ways of how can we make more of an impact beyond one program a year, have more continuity between the programs. And so that's what's really led to the creation of this series and being able to provide more programming around these important issues. As I mentioned, if you would take a moment, if you have not yet done so, please fill out the demographic forms that were in your folders. This just helps us have information for funders when we go to apply for money to support these programs, to be able to offer more programs. Also in your packets you have an agenda. You'll see we're going to start off today's program with a couple of speakers talking about a range of issues related to health and wellness and aging. And then after that, we're going to have a lot of time for a Q&A with all of the presenters, with everyone here, some time for discussion, time to ask your questions. So we do ask as much as possible, try to hold questions until the end, just so if you have a question, it might be covered by one of the speakers coming down the line, and then having questions at the end, all of our panelists will be able to jump in. Thanks to ACO, the AIDS Activities Coordinating Office, who is the sponsor of our program today. Also thanks to the Philadelphia Gay News, who are a sponsor of all of our programming. Would like to give some acknowledgement to the Colors organization, who are in the back of the room, have a lot of supplies and resources that I would definitely encourage everyone to check out at the end of the program. As well as a lot of resources from the Elder Initiative, some resources from Walgreens. Walgreens also supplied the sample pill packs that are at each of your tables, and you can feel free to help yourself to some of the candy in there. It is to share with your table, but help yourself throughout the program. So, without further ado, we're going to get things started off with Dr. John Stern. Dr. Stern is a good friend of the Elder Initiative, has helped us out with programs in the past. He's going to be up there talking about some of the physical health aspects of aging and HIV. And I will turn it over to him to let you tell more.
So just a little bit of introduction. You've heard my name is Stern. I work at Pennsylvania Hospital, where I've been doing primarily infectious disease and some internal medicine since the late 80s. It's been a wonderful place to work. I really enjoy it. My first encounter with HIV was when I was a resident at the University of Texas in 1981, when a gay man commuting between San Antonio and New York developed central nervous system toxoplasmosis, and we had no idea what was really going on with this guy and why he got sick, and he eventually died. And sort of each week at our conference, we'd say, what is with this patient? We thought, this must be some bizarre virus. And then obviously within a couple of years, we understood what was going on. So here we are, fast forward from 1981 to 2015. So we're 33, 4, 5 years into this epidemic. Probably you're aware, probably the first case in the United States was maybe 1959 or so. So it's been around. And the first case probably on Earth is thought to be in the 1920s out of West Africa. So now we're up to about 1.2 million infected people in this country, somewhere in the 30 to 40 million people infected worldwide. The United States is experiencing somewhere in the range of about 45,000 new cases per year. So despite all of the knowledge, technology, funding, everything we know about, this epidemic just does not seem to want to go away. Of the 1.2 million infected in the US, Only about, and these are numbers from ACO, my partner Kathleen Brady, who's the epidemiologist for the city, actually works for me part-time, generates these numbers. Only about 870,000, so sort of 3/4 of the infected population in the United States actually knows that they are indeed HIV positive. So there's a huge reservoir of people that are infected and don't know it. And obviously, if you're out of care, your viral load is high, it is a particularly at-risk group to spread this virus. The mathematical statistics are that apparently if we could get all 40 million worldwide HIV-infected patients in care and get their viral load down and maintain that within 60 years, so 3 generations, we could eliminate HIV from the world, which doesn't seem such a challenge considering that we've been able to eliminate simple diseases like smallpox and a variety of other vaccine infections that we can control with vaccines. Let me give you some numbers. Of the 870,000 people that know they're HIV positive, only somewhere in the 600,000 are people actually going to a doctor for their HIV, know their status and said, I need a doctor. And what's really profoundly sad is that probably only about 250,000 in this country know they're positive, see a doctor, take their pills, and have achieved a sustained suppression of their viral load. So only 20% of our entire population at risk here are getting proper treatment. The reasons, the barriers obviously for getting on therapy are obvious. It's insurance, money, access, mental health, drug abuse, denial, and probably the list is as long as my arm, but it's really unfortunate. Here in Philadelphia, we have about 20,000 infected in the city itself. There's about 25,000 that are infected in the metropolitan area. We have, believe it or not, about 625 new HIV positive diagnoses a year here in the city itself. And we've had only 165 HIV-related deaths in 2014, which is dramatically down over the past few years. I think about 4 years ago, according to Kathleen Brady, it was about 500 deaths. So we're doing well in terms of that. Some really unfortunate numbers. If you look at the African-American population in this city, just take all comers, 3% of them are HIV positive, 3%. If you look at African-American women, it's 1%. If you look at white populations, it's well below 1%. So that unfortunately, this is an illness that is disproportionately affecting African Americans, clearly here in Philadelphia and across the United States. If you look at who's getting this illness, it's clearly men who are having sex with men. They represent 60% of all the new cases, both here and across the country. And surprisingly, intravenous drug use, which used to be a substantial contributor to the epidemic, has really dropped off and is just a few percent. Reasons for that are primarily needle exchange programs. That despite the brilliant Republicans in Washington who think that it actually promotes drug abuse and problems, it actually is incredibly appropriate and healthy. You know, you treat drug abuse in a different way than denying people clean needles. But it's quite fascinating that we've really been able to eliminate IV drug use as a methodology for transmission of HIV. Let's talk a little bit about transmission using simple language instead of medical language. Top and bottom for men who are having sex with men. If you are HIV positive, not in therapy, with a positive viral load, the chances of you getting HIV is about 1.5% every time you are on the bottom of having sex with somebody who is untreated HIV positive and you have receptive anal intercourse, as doctors call it. The flip, if you're on the top, the risk is a tiny 0.16. So obviously it depends on how one has sex. Your risks are huge if you're on the bottom and rather small on top. What is the contribution of oral sex? Frankly, no one knows. Just no one knows. It's not zero risk, but it's small. So just transitioning this talk a little bit away from HIV and just talk about health-related issues for men who have sex with men, let's just go through the STDs, are now called STIs. I don't know why they decided to change this, but they did. And go through what folks are at risk for, and certainly what I'm seeing. Aside from HIV, HPV, or the wart virus, is really prevalent in all communities. Unfortunately, if you're HIV positive and you're a gay man, warts are a much more serious problem because in the setting of HIV plus HPV, the risks of developing anal carcinoma, anal cancer, is 30 times greater than if you're HIV negative. How do we screen and prevent it? For me, I look carefully. I'll do rectal exams. Some people think that cytologies, basically pap smears of rectal swabs, is useful. There's really no standard way to do it, and no one quite knows if we should be doing that for all of our men who have sex with men. I don't do it. I haven't found a lab that can reliably do it. So HPV is problem number one. Syphilis. It is here, happy and alive and well. I see a case of syphilis in my office probably every 2 months, every 3 months, and in the last year I've had 2 cases of ocular syphilis. What happens if you're HIV positive is that you get a very, very accelerated form of syphilis. Let me flip it and say that if you're HIV negative and get syphilis, it takes about 30 years from it to go from genitals or mouth or skin to brain, 30 years. If you're HIV positive, it takes about 6 months. So you will develop first skin lesions, you will then develop eye lesions, eye problems, chorioretinitis, an inflamed retina, and meningitis. And there's an epidemic going on in Philly, and there's been recent reported cases by CDC across the country. Seattle's having an epidemic. So syphilis is alive and well. And I try to remind myself to always be checking for syphilis in the blood tests. Gonorrhea, always some gonorrhea. Mostly in Philly, it's in young men. Seems to be in specific populations. So the older you are, the freer you are from getting gonorrhea. I guess that's the one advantage of getting old. I guess low T may be your best friend. It certainly prevents this sort of thing. Chlamydia, we're seeing plenty of chlamydia urethritis and proctitis. I tend to see a lot of chlamydia proctitis in September after my patient population spends part of their summer on vacation up in the Poconos at Hilltop, I think it's called. There's a couple of other gay camps. It seems to be incredibly prevalent there and certainly puts people at risk. Hep C, about 3 to 4 million people infected in the United States. Most of them IV drug users, many of them healthcare workers like myself, people who have received transfusions, and certainly men who have sex with men and are often co-infected with HIV. HIV drives Hep C. Hep C drives HIV. They both need to be treated, even though many insurance companies don't want to treat the Hep C, even if you're HIV positive, until you develop cirrhosis. The data says that's stupid, but I'm not an insurance company. But first you treat the HIV, and then you go after the Hep C. Did I say that right? First you go after HIV, and then we go after Hep C. Hep A, not particularly prevalent in the United States. It is a fecal oral virally transmitted illness, mostly in the developing world, but it is certainly a sexually transmitted disease. How can we prevent some of these illnesses using immunizations? Just to back up, turns out that immunizations in clean water are the primary drivers of a prolonged life expectancy. Back in the turn of the 19th century, the last century, life expectancy was somewhere in the mid-40s. Obviously now it's in the mid to late 70s. Most of it is due to clean water and immunizations and good food. It's not due to doctors' good care. It just isn't. We may add 3 or 4 years to life. That's it. So let's go through some of the available immunizations that everybody should get, irrespective of your age. All men who have sex with men should be either immune or be immunized to hepatitis B. 3 shots, easy enough. Hep A, the same, unless they are immune from prior exposures. Let's talk about Gardasil, which is the wart virus vaccine. Insurance will pay for it in kids up to the age of 26. It's expensive. It costs for 3 shots about $400. That's the cost of it. That's how much we charge in our office. We make no money out of it. My feelings are that unless you're in a monogamous relationship, and everybody is in, anybody that's out and about having sex with other folks should get this Gardasil vaccine irrespective of their age. It's a little expensive, and insurance won't pay for it. But it certainly prevents cancer, and it probably protects you against non-cancer producing viruses. And those with cancer who have it treated, burned, and so on, burned off or removed surgically, their outcomes are better if they've also been immunized. Fewer of them go on to get recurrences and cancer, just recently published. So one can't overemphasize the value of the Gardasil vaccine. It's not a kid's vaccine. Why is it only being paid for by insurance up to age of 26? Real simple. The manufacturers of the vaccine studied it in kids up to the age of 26 because that was the easiest group to show that it was effective. These are mostly young people that had not had their sexual debut. You can prove that it worked. Unfortunately, the FDA gave them an approval based on those studies up to the age of 26, so the insurance companies follow suit and say, we're not going to pay for anybody over 26. What else do we have? We have the meningococcal vaccine. There have been several outbreaks of meningococcal meningitis, particularly amongst men who have sex with men in New York City. So if that's where you have your sex life, you might want to think about the meningococcal vaccine. Flu. Everybody here should be immunized. Everybody should be immunized. There's a high dose. It's got 4 times the amount of flu vaccine in it for people over 65. Get it? It's really important. Everybody who's HIV positive, everybody who's over 60, or everybody that has basically anything wrong with them. Liver disease, kidney disease, heart disease, asthma, whatever they got. If they got 2 feet and a pulse, should get Prevnar 13. Which is the new pneumococcal vaccine that is incredibly effective. And then a year later, you can chase it with the old-fashioned pneumococcal 23 vaccine. Okay? And lastly, the zoster vaccine. Everybody over 60 should get a shingles vaccine, whether you're HIV positive or negative. The only people that we hold up the shingles vaccine for are people with CD4 counts less than 200. We wait till their CD4 count is up above 200 to prevent disseminated disease, although that's really never seen. Other aspects of aging and so on. Let's talk a little bit about smoking and HIV positivity. It's now been shown fairly clearly that if you're HIV positive and you smoke, you have a somewhat increased risk of developing lung cancer. Lung cancer. Can that be at least early detected? The answer is yes, and insurance will pay for it. The studies are now clear that if you get a low-dose CAT scan of your chest, you can pick up early lesions that can be dealt with before it's too late. Unfortunately, when I offer that to my smoking patients, they'll go, forget about it, doc. I'll deal with it. I don't want to know I got lung cancer. I'll deal with it when I get it. Denial is more than a long river in Egypt. In addition, smoking will put you at risk for pancreatic cancer, gastric cancer, and bladder cancer. It will put you at risk for strokes, heart attacks, impotence, peripheral vascular disease. Your feet will go numb. Your feet will fall off. It's unfortunate that more HIV-positive men who have sex with men smoke than their counterparts, straight men who are HIV negative. People are under stress, they smoke. It is a wonderful, relaxing agent. It just isn't particularly healthy. Is vaping better than smoking? You heard it here. Yes. Is it safe? I don't think we know yet. Is it safer than cigarettes? Absolutely. The carcinogens are not the nicotine. It's all the other molecules that are in the tobacco. How are we doing for time? I'm fine. All right. Let's talk a little bit about preventing HIV in the world we live in. There is PrEP, pre-exposure prophylaxis. If you are part of a couple, discordant couple as we call it, one's positive, one's negative, and you want to make sure you don't become HIV positive, you can take Truvada once a day. You won't get it. If you're lazy, you can take it 4 times a week. You still won't get it. If you're really, really lazy, as long as you take it within the day before you have risky sex and for 2 days after you have risky sex, you'll reduce your risks of developing the disease by about 80%. Are discordant couples whose HIV positive partner has a truly controlled virus? My feelings are they will not infect their partner. They can give each other other things, but they will not. There's sort of this very tiny group of people that will shed some virus in their semen who are well controlled in their blood. It's an incredibly small subset. Living in the real world, it's a pretty safe way to have sex if you're discordant and your partner is truly taking his meds. Let me grab my notes. Barely. Post-exposure prophylaxis. If you have some high-risk sex with somebody you don't know and you're HIV negative and you want to make sure you don't seroconvert because your risks are 1.4%, if you're on the bottom, you can do post-exposure prophylaxis, primarily with Truvada and Tivicay, dolutegravir, or Truvada and raltegravir, Icentris, 28 days. Do we know if it works? We don't have great studies in humans, but we have terrific studies in chimpanzees, in simian models. It really works in monkeys. So we believe it works in humans. Alcohol, clearly a problem amongst everybody. In this country, 10% of this country has an alcohol problem. I don't think that in HIV positive or men who have sex with men, alcoholism is a particularly different issue. It's prevalent. I'm a big believer in AA and being honest about it and dealing with it. It's a gene. It's not anything you've done wrong. Those who are alcoholics have a gene that makes them alcoholics. Okay, just like having risks for heart disease and every other disease. It's just a disease. It can be dealt with. Can't be cured. Depression and anxiety, clearly a problem for everybody in the world, in America. If you live in Syria, I can't imagine what it must be like. But being HIV positive certainly carries its significant burdens emotionally, privacy, concern about one's health, being outed, and so on and so forth. I would say that probably 25–35% of my patients are on an SSRI, that's Prozac, Zoloft, Lexapro, Celexa, Cymbalta. They're great drugs, they're terrific, they're helpful, they have no interactions with all the other drugs. They really help people feel a little bit less upset, angry, anxious, depressed. They sleep better. It screws up your sex life a little bit, but most people are willing to give up a slightly screwed up sex life to just sort of feel globally better. Great drugs, wonderful experience, really safe. Some general health issues about just getting old, whether you're HIV positive or negative. But let's talk about probably the biggest issue in HIV positive, older men and women, is coronary artery disease. Coronary artery disease is not just your cholesterol. It is an inflammatory disease, and HIV drives inflammation. Most of my patients, if I can get them, are on a statin. That's Lipitor, gets simvastatin, atorvastatin, rosuvastatin, Crestor. So pravastatin, although I'm not a big fan of pravastatin because it doesn't work very well. The trouble is that its counterpart in our little world is very expensive, Crestor or piastatin, very expensive. I think everybody should be on a statin, personally. These drugs are incredibly safe, relatively inexpensive, and are very effective. I think that all men should be on an aspirin for prevention of heart disease and stroke, unless you happen to have a bleeding issue and you can't take it. For women, the data is not nearly as good, and I don't push aspirin on women. But for men, all of my patients who are certainly HIV positive are on a statin and an aspirin. I'm very liberal about ordering stress tests on anybody with any history of smoking or shortness of breath, chest pain, and so on. At the age of 60 and then 70, you need a colonoscopy, HIV positive or negative. The number 2 cause of cancer deaths are due to colon cancer. Number 1 is lung cancer. In women, it's actually lung. It used to be breast, it's now lung, and breast has gone to 2 and lung has gone to number 1. 21% of this country smokes. It's great for the tobacco industry, it's great for business. You know, it puts my kids through college, but that's kind of pathetic. All right, a few other issues. We talked about immunizations. Let's talk about osteoporosis. Osteoporosis in men is profoundly under-recognized and diagnosed. If you are a smoker, even if you're a man, great risk for thinning of the bones. I try to get DEXA scans on all my smoking men, particularly HIV positive, and we treat them with a variety of medications. In addition, anybody who's taking Truvada, that's the tenofovir component, will waste vitamin D and become at risk for osteoporosis. Anybody on Truvada or drugs that contain Truvada should be on vitamin D and calcium supplements, around 1,000 international units of calcium, of vitamin D, and probably somewhere around 400 to 800 milligrams of calcium, a gram of calcium. Nobody really knows. Oscal-D. Prostate cancer. Should we worry about it? Well, the literature says forget about it, that we're going to die with it, not of it. I try to talk people out of getting a PSA because I don't want to chase it with biopsies and prostatectomies, which make you septic, impotent, incontinent, and really don't add a whole lot to life expectancy. But I make it a patient choice. And lastly, exercise. I think it's good for the mind. I don't think anyone has ever shown that exercise helps you live longer. And my last point is dementia in the aging. It's a problem whether you're HIV positive or negative. About 5% of people who are HIV positive will get pretty significant dementia. Probably most HIV positive people will have some subtle cognitive disorder. Is there much that we can do for it? The answer is probably not. If you're well controlled on whatever regimen of HIV meds that you're on, whether they are shown to be CNS penetrating or not, they're basically all equal in terms of slowing the potential for dementia. Some people in some settings will do lumbar punctures and look for detectable viral load in the CSF, even if the viral load in the serum is negative. The trouble is, even if you're positive, no one knows what to do with it. So dementia, I think, remains a really difficult issue. Fortunately, most HIV positive men may develop some subtle cognitive problems, but not really get terribly demented. But we're not doing very well, I think, dealing with it, and hopefully things will improve at some point. My hope is that if you take a statin and take your aspirin, that at least you can prevent the inflammatory component that contributes to it. But that's a story to be continued. So I think that those are the areas that I wanted to talk about. I'm sure you'll write down your questions and we'll come back to it.
Thank you very much to Dr. John Stern. And we are next going to bring up Wayne Marquardt. Wayne is a clinical pharmacist with Penn Medicine. And as soon as we get the mic set up here. Wayne will be up here to speak about medications, medication safety, medication adherence. And so without further ado, I will turn it over to Wayne.
Thank you. My name is Wayne Marquardt. I am a pharmacist at the University of Penn Hospital. I've been there for about 33 years now. My specialty right now is more women's health. I take care of women in labor and delivery, and I also take care of the neonatal population. But prior to that, I spent about 15 years working with the Philadelphia AIDS Task Force on a lot of the medications and talking about and going to outreach. And what I'm here for today is to talk about specifically safe medication use. So can anyone raise their hands here today who is not on a medication, not on a vitamin, not on a cholesterol pill, not on a hypertensive pill, not on an HIV medication? So I see no one in this audience who this doesn't refer to or doesn't resolve to it then. And what I'm going to be talking about for the next couple of minutes is how to take a look at your medication. And let's talk about medication safety. One of the big things that we're seeing now with the explosions of medications on the market, when many of you were first born, when your grandparents were there was only a handful of medications out there. There were only a handful of antibiotics. There were very little in the way of meds for hypertension. There were very little meds in the way for cholesterol. And now all of a sudden we're seeing this explosion of medications that are coming out. And it was just Dr. Sterner just talked about, the amount of meds that are out there for not only HIV, but for heart disease, liver disease, hypertension, hypercholesterolemia, all those other things. It has expanded tremendously, and it's taking a number of all of our healthcare practitioners, pharmacists, PAs, physicians to actually keep up with all this and to take a look at how our populations can safely and effectively utilize their medication. So if we can go to the next slide there. So how to start is one of the big things that we want to take a look at is saying that you really need to hopefully use the same pharmacy for all of your prescription and over-the-counter preparations. And the reason we usually suggest this is the fact that as a pharmacist, I can keep an entire listing of your medication, so I know exactly what you're on. If you go from a CVS to a Rite Aid to your hospital pharmacy, each one of us has our own computer system which keeps all this information, but unfortunately, it doesn't share with anybody else. These are all very proprietary information, so we may only be getting partially of your idea of what medications you're totally on. So just make sure that your pharmacy carries a complete profile of all your medications, and then anything else that you're going on. So if you decide that you're going to go on vitamins, if you decided that you are taking that aspirin on a daily basis, that your pharmacist also knows that as well. Next slide, please. And the big thing here is knowing the indication. And the indication means, what are you taking this medication for? Why are you using it? How is it being used? How often? I noticed that with a lot of our elderly population, and especially those in their 80s and 90s, who are on medications, they were brought up in an era where the physician knew everything. You went to them, you didn't question it, you just took the medications. We're now taking a bit back, and we're trying to put this much more into the consumer hands as well, so that you know what you're on. Because before it used to only go to one physician, and that physician took care of everything. Now you have your dermatologist, your gynecologist, your ophthalmologist, you've got your internal medication, you've got your surgeon, you've got your podiatrist. All these people can be prescribing medications, and if we don't have a centralized location, this is where a lot of damage can occur with drug abuse and drug misuse. If you're requesting that this information, one of the big things I specifically ask for all my geriatric and elderly population, and actually for my younger population as well, for parents, is you can actually request that information to be placed right on your prescription label. So this is your hypertension medication. You're taking this once a day for your cholesterol. You're taking this twice a day for your blood pressure, whatever it is. But making sure that you keep that information and that you know exactly what those medications are using for, because this is not only going to help you, but if you have someone who's also helping in care providing, it's going to help them as well. And keep a list of this information around so that you can use it. And one of the things I brought in the back, which I hope everyone would take with them sometime today, is what I call a personal medication card. And this is something which should be hanging up on everybody's refrigerator, in a pocketbook, someplace that if you do need to go to a hospital, you do need to go to an emergency room, you are seeing a physician for the first time, you can bring a list of all this medication with you So that when a person is being placed on another or a different medication, you can ask your pharmacist or you can ask your physician or your healthcare provider, is there going to be any interactions onto this, or what do I need to look at this? And one of the great things right now for those of you who have not been in a hospital recently is that we are now all required to do what we call a medication reconciliation, meaning that when you're coming in, you may have a pharmacist, you may have a nurse, you may have a physician coming in and talking about your medications and putting down a list of those medications that you're currently on. And then while you're in the hospital, if we are putting you on anything else, you will be informed of what that medication is, why it's being used and how it's being used. And then when you're discharged, and this is where the big problem comes in a lot of times, is that you should be informed what medications you're going home on, not just new prescriptions, but what prescriptions you are going to continue to take. Because probably about 25 to 30% of readmissions coming into a hospital, especially through our emergency room system, are patients who have come into a hospital, have been on a bunch of medications, we've switched them around, gave them new prescriptions, sent them home, and not only did they take the new prescriptions, they were taking the old ones as well, and a number of drug interactions I've seen with that. So it's really important of sharing that information with your healthcare professionals and making sure that you understand exactly what you're going to be on once you're discharged, or if a physician has changed the medication. Okay, next slide. One of the big things here is also knowing when to take your medications appropriately and properly, and how you're going to take them in a timely manner. Know the proper times to take medications. There are certain medications you want to take in the morning. So those of you who may be on a thyroid preparations, the information shows that you should be taking this actually very early in the morning prior to breakfast. These drugs seem to be working much better at that point. If you're taking a medication in the evening, knowing some of the side effects, or if you're taking a sleeping pill, just remember that a sleeping pill, if you take it at midnight, and you want to go to bed and sleep at midnight, you should probably be taking that about an hour earlier, about 11 o'clock or whatever. So taking them at the proper times are always going to be the way to ask either a pharmacist or a physician or one of the other healthcare practitioners to say when is the appropriate time to take this. Are there any dietary arrangements? There are drugs which you want to take on an empty stomach. There are drugs that you want to take with a fatty meal. There are drugs that you need to take with some sort of food or water, or there are lots such as antibiotics such as Bactrim, trimethoprim, sulfamethoxazole. You really want to take a full 1 to 2 full glasses of water with this, because this can cause a crystalluria, which can be very, very painful. And then again, knowing whether the drug should be taken on an empty stomach or whether it should be taken on a full stomach. Next slide. And anyone here on injecting themselves with insulin needles, or anyone here using asthmatic preparations where you're taking inhalers the whole bit? One of the big things that we see a lot of times also is our emergency room. Probably about 25% of our asthmatics who are coming in are doing so because of the fact that they've never really been taught the appropriate way on how to use an inhaler, or how to self-inject themselves with insulin, or if they need an EpiPen, what is the best way of doing this? So if you do have equipment at home and I'll say this is equipment, making sure that you know how to use it appropriately. If you're on a blood glucose machine, so if you have an Accu-Check or whatever, making sure you know how to use them. So get a person who really knows what they're doing, because a lot of times what happens is you get a prescription written, you go out, you get it filled, and you're coming back and you're trying to read the instructions and it's really not there. So making sure that you know about how to use these things once you're getting home. Injectable equipment, and one of the big things, let's say eye drops, one of the big problems that we've had, and Shea Eye Institute sees this quite often, are a lot of optic infections because of the fact that the patient is taking their eye dropper and putting it right in their eye. So whatever infection that they're taking care of, they're actually keep reinfecting themselves. So there are appropriate ways of making sure that you apply these medications without, number one, contaminating the product itself, and number two, that you're not reinfecting yourself. Next slide. Medication storage is always going to be a big problem. Knowing when and how and where to store medications are going to be really, really important. Avoid excessive heat or light. Medications, when they're being studied by the manufacturers, are never placed on a sunny windowsill. We know that heat and light can destroy a number of medications. If the drug is supposed to be refrigerated, making sure that the appropriate temperatures are maintained in your refrigerator. One of the big things that we've seen in the city in the past couple of years, the city gives out tens of thousands and worth of doses of flu vaccines and other vaccines, which Dr. Stern was talking about, only to have them being recalled because when the inspectors go out to take a look at the refrigerators are too warm and we can no longer guarantee the efficacy of those drugs. So making sure that if you are storing these in a refrigerator or a freezer for some of the things that the temperatures are appropriate. Shake well, especially if you're looking at an oral suspension, making sure that the drug is shaken up because, or also, I should say this as inhalers as well, as making sure if you're taking your inhalers, shaking them up. These are suspensions. They are particulate matter suspended in a liquid. And if you don't shake them up, you're not going to get that dispersal. So you're going to get a lot of drug at the beginning and no drug at the end, or you're going to get no drug at the beginning and a lot of drug at the end. Expiration dates are really important for just a handful of medications, to be quite honest. If you take a look, you'll have a expiration date for most meds. We really do recommend that, but usually if it's a few days out, it's not going to worry. But there are certain drugs, antibiotic suspensions especially, are really not viable after their 12 to 14 to 28 day expiration. Nitroglycerin, one of the big things for those of you who have cardiac problems or are taking nitroglycerin, once that bottle has been opened, it's only actually good for 6 months after that because you get a lot of moisture that's going into that bottle at that point, and that can actually degrade the tablets and make them not as effective as they should be. So avoid high humidity on those things as well, making sure that they are being kept at a proper temperature. Okay, next. And special preparations. One of the big things that we find out with a lot of our manufactured medications is that they're not consumer friendly. You have very large tablets, very large horse pill capsules a little bit, and people a lot of times have difficulty swallowing these type of preparations. If that is the case and you're going to be crushing these tablets or if you're going to be emptying out capsules or whatever, before doing so, check with any of your healthcare professionals, again, a pharmacist, your nurse practitioners, your PAs, your physicians, to make sure that that is appropriate. A lot of these preparations, especially if something has XL for long-acting, SA, sustained action, sustained release, any of those type of things, you crush them, you open them up or whatever, this is now an immediate release product and it's not going to last the 12 or 24 hours, which it's supposed to. So before you do any of those type of things, check with a healthcare provider before you crush them. And if you are splitting tablets, split them only with approval of a pharmacist or physician, because again, the same thing. Some of these products are made as sustained release, and as soon as you open them up, the gel inside no longer is going to give you a sustained action. The other thing I would suggest is that if you are taking a tablet and you are cutting it, and you do have the permission for that, making sure that you get a good razor blade or go to any of your pharmacies and get a tablet and pill splitter or a pill crusher. Last thing you want is a knife and trying to get things out because you may not get the exact dosing that you're looking for at that standpoint. Okay, next slide. And one of the big things I want to give everybody permission here for is to be an effective consumer. Just because you have been prescribed a medication and I'm filling it for you or I'm dispensing it to you, you have the right to know everything about that medication, not just what it's being used for. But one of the big things here is understanding any of the side effects or potential side effects of those medications. There are certain drugs which will work together. There are certain drugs which will not work together. So consult your pharmacist, consult your physician or your healthcare provider, and read the patient information. Most pharmacies are by law, when you get a new medication for the first time, will have some sort of document that goes along with it. Big documents here, they're usually sometimes 2 or 3 pages long. There are a lot of information, but you can get the information that you want there. The big thing that happens with these, though, is that depending on the pharmacy that you're going to or the physician's office that's supplying the information can be in a lot of big word medical jargon, which is not understandable. If you don't understand it, please go back and ask somebody for it, because it's something which actually can affect your life. And this is one of the big things we see in a lot of our emergency room situations. And use medical references. There's a ton of good information out online right now. That being said, there's also a ton of non-viable information, which I would say kind of stay away from. But if you're going into such areas as Micromedics, UpToDate, Lexicomp. These all have our online areas where you can get some really, really good information, get it up front, and it's done at an 8th grade reading level where everybody can actually understand the information that's going through. And again, if you need to, this is one of those areas where you then can call back and make an appointment with your physician, make an appointment with a pharmacist to sit down and discuss a little bit more detail whatever your concerns are, what their concerns are. And again, that's one of the big things we'll see when you're in a situation where you're being given a medication. A lot of times a pharmacist may not, at that point in time, be able to sit down and spend a half hour with you at that point because there's 30 other people waiting behind you. Or if I'm in a hospital situation, I may have a patient crashing, which I need to deal with. But we certainly will be able to make some time to do it. It might just not be at that point, but certainly feel free and be empowered to ask questions about any of this stuff. When should I be taking this? What should I be asking? What are the side effects? What do I need to take a look for? Do I need to come back for blood tests? Do I need to come back for other sorts of measurements? Or is there something else I need to take a look at as well? If this is not working, when should I come back to see you? These are all very, very valid points, and any healthcare provider should be very receptive to those types of comments and questions. Next comment. And taking a look at side effects. Side effects and allergies are two really, really different types of animals when it comes to taking medications. I've had people saying, well, do you have a side effect for a medication? And they told me that they don't like the taste of it. That's not really a side effect at that point, but the other part is that I've had transplant patients who have refused to take some of their anti-rejection medications because they didn't like the taste of it, and that becomes a problem. So, when you're taking a look, real or perceived, side effects as compared to, are you having an adverse reaction to it? Are you now taking a medication and you're now turning pink with green spots? Is your throat closing up and you're having difficulty breathing? Are you taking a medication that all of a sudden you're having vivid dreams? Are you taking a medication and all of a sudden you can't get up the next morning, you're just so tired? These are things that you really want to go back and discuss with your healthcare professional. And again, it's one of those things that sooner rather than later, because some of these things can be dangerous in the long run. And then one big thing which I think all of us as healthcare providers will want to let you know is that when we're talking about medications, I'm not talking just about prescription medications. I am talking about anything that you're taking, including over-the-counter medications, herbal medications, natural remedies, the whole bit, because all of these, just because you can get them without a prescription doesn't mean that they're not safe. There are people who have reactions, and to be quite honest, there are a number of healthcare professionals who said today that if aspirin was just coming on board, it would probably be a prescription product. Or on the other hand, we're taking a look now saying that some drugs such as our H2 blockers or Zantac and some of those other things, which were a prescription for the longest while, are now over the counter, or such things such as ibuprofen. Low dose is over the counter, high dose prescription strength is 600 and 800 milligrams are prescription. So taking a look and making sure you're knowing how you're taking these medications and if they are going to interact is tremendously important. Many of these medications can interact negatively with other prescription medications, so this is one of the reasons that you want to keep an open mind when you're taking these and being very honest with your healthcare practitioner about what you're taking. Use over-the-counter medications only as directed if you're taking it as an over-the-counter product. If your physician wants you to take it in a different way, that should be his or her decision, but don't make that decision yourself because, again, you can have some very serious side effects with this. And a chronic use, only with a physician. So one of the big things is, what's one of our most overly used and very common pain medications over the counter? Tylenol. University of Pennsylvania did a study a number of years ago. Tylenol, which is a acetaminophen, which is a very commonly used analgesic for anything from headaches to muscle pain to cramping, things along that line. We found out over a 5-year period that the people who were coming into the hospital of the University of Pennsylvania for Tylenol overdoses was not because of the fact that they'd taken a handful of Tylenol and were trying to end their life. It was the fact that they had been on this chronically without talking to a physician and getting that. And at that point, all the remedies that we could use to reverse those toxicities were unavailable or would not work at that point, and these patients ended up going for liver transplants. So, these drugs over the counter are not without side effects. So please just, in a chronic standpoint, take your time. And then the big thing here also is just making sure, and this is one of the areas of my specialty, is that children especially and seniors are not a lot of times included in a lot of these studies for dosing guidelines. So when you do become older or go working very young, check the use of those drugs in those areas, because sometimes metabolism does slow down and doses need to be changed in those areas. Check with specific medical conditions. Some of these drugs can be used in, you may not want to use them if you have hypertension, but you also have cardiac disease, something along that line. You may want to be very, very careful. And this again is where a healthcare professional will come in. And with seniors and the elderly, again, because body systems slow down, you metabolize drugs a little bit slower. Your kidney function may not be working as well. Your liver functions may not be working as well. Things along that line. Again, your healthcare professionals should be able to make sure that these doses are appropriately monitored for not only your age, but how the effect is going to be. How do you take your medications? How many people here, when they're taking a medication, take it with a sip of water? Okay. Well, most of these drugs are actually designed to be taken with a full glass of water. Drugs such as ibuprofen, Advil, things of that sort, these are propionic acids. They can lay in the stomach. And one of the reasons that you hear about drugs causing ulcers the whole bit is the fact that these drugs are not diluted out appropriately in the stomach. So making sure that you take with a full glass of water or with a meal to make sure you're taking care of those type of side effects. Check with your pharmacist or healthcare provider again if meds can be taken with food. Some are okay, others are not, or you may need special dietary requirements such as high fatty meals, things along that line. One of the big things that you do here, and this is true, is that grapefruit juice on a lot of medications, especially the statins, should be avoided because of the fact that these drugs are not really metabolized appropriately with grapefruit juice. And antibiotics. Anyone here not been on an antibiotic regimen or therapy? No. Whenever you're on antibiotics, if your physician prescribes a 14-day supply and a 14-day course of therapy, make sure you take the entire 14 days. One of the big things that we'll see from a reinfection rate is that people take medications for 2 or 3 days, start feeling really great, stop taking it, and then all of a sudden that infection comes back again and it's hitting them worse than it has been before. The other part of this is that even though you are taking these prescribed medications, don't save these medications for another rainy day, because just because you feel achy and fluish and this drug worked this one time, next time you feel achy and fluish or something else is going on, that antibiotic may not be the one that you need at that point. So make sure that if you are not finishing medications, that it just gets discarded. Antibiotic suspensions are usually given only a 2-week supply in the refrigerator, and then after that they should be discarded. There's very, very few medications, by the way, which probably shouldn't be saying this, but I will, is that even if they're outdated, they may lose some of their potency, but they're not going to hurt you. But there are certain antibiotics, other drugs, that after a period of time, tetracycline being one of them, actually can cause something called Fanconi syndrome, which is a syndrome that we've seen just specifically for people who are taking outdated tetracycline, which has a lot of liver involvement. So if you're not using the drug, just discard it. Big thing here also, and one of the big things is how do you discard medications? One of the things that most people used to tell you is dump them down the sink, dump them down the toilet. That's no longer appropriate. We now are having measurable levels of antipsychotics and antidepressants and other medications in our water supply. Our goldfish are happy. So if you are doing these, the recommendations are now to dispose of them in the trash and mixing them with kitty litter or something, or returning them back to the pharmacy. If you have controlled substances, usually 2 or 3 times a year, the city of Philadelphia does take back controlled substances at certain police stations, and those are very well publicized events. Okay. And not that I have to worry mostly about the men in here with pregnancy and breastfeeding, but again, in my population, this is very important. Certain drugs, though they're healthy to the mom, may be deleterious or have very negative effects on the unborn child. And whether that's in utero or whether the mom is breastfeeding, big thing here is that, again, so if you have any of your children, grandchildren, or people who that are on medications who are pregnant, have them checked, make sure that their meds are checked out with a pharmacist or a lactation specialist or a physician. And last slide. I'm not going to go too much into immunizations, but again, immunizations are tremendously important. As we grow older, they seem to be much more of our friends. And just as this gentleman said here, natural and herbal remedies. Big thing here is that any herbal remedy that comes out on the market that you're getting through your GNC or your herbal medication stores a whole bit, these medications, these products are not regulated by the FDA. So there is no guarantee that what you're buying is either, number one, the true product, or that you're getting whatever is mentioned in there. And I'll say this something like for ginseng. A lot of people will use like ginseng for mood elevations as a kind of natural antidepressant a whole bit, also to give you a lot more energy. Taking a look, there's an American ginseng, there's an Asian ginseng. They both come in separate formulations. They come as a tuber, which then can be ground up. But a lot of times also you may not be getting the real ginseng at that point. Instead of getting the root and the tuber that is being used, you have manufacturers now who are just taking the plant material itself, the leaves, grinding them up, which has like about 1/10 of what the product is in the root section. So you're getting that drug, but you're not getting anywhere near what it is. And none of this is regulated. So just be very cautious of the products that you are buying and making sure that if you are getting them, they're coming from a reputable dealer. And again, as I mentioned in the back there, make sure that you do have a medication profile of all your medications, not only for yourself, but any of your loved ones, and making sure that that is available. So just in case you do go into a hospital, you know, that there is an accurate list of medications on you. And for a number of health systems right now in Pennsylvania, or University of Pennsylvania and Pennsylvania Hospital Health System, our system now is set up so that any doctor who sees you within the health system can actually access all your medical records and see all the medications that you're on. And then I know that the physician that I go to, every time that I go in, I sit down, he opens up my medication profile and saying, Wayne, are you still on all of these drugs? So this is one of the great things that's coming out with electronic medical records right now. We're going to have access to this information. But again, any of the information that you have, just making sure that you know the drug, what it's being used for, the strength, and how often that you're giving it. Because my two counterparts over here, how many times have you had a patient comes in and said, I'm on a white tablet for my blood pressure?
Every day.
And that's not helping us or anybody whatsoever. It can actually help impede a diagnosis. So making sure that you have this information is not only going to be helpful to your healthcare practitioners and healthcare providers, but also to yourself in making sure that you're getting the best possible and quality of care in a very reasonable amount of time. And again, just ask questions. Anytime you have a question, you are the consumer. You're paying us for our services. You should be getting it. And that's it. So I want to thank you very much for your time, and I'll be around afterwards to answer any questions.
Thank you very much, Wayne. So we're next going to bring up Dusty Latimer. Dusty is with the Mazzoni Center, and he's going to be up here talking a little bit about ways to communicate with your healthcare providers to make sure you're getting your questions answered and getting the most out of your visits.
So I'm Dusty. I work at the Mazzoni Center. I'm a primary care provider. So what I want to talk to you all about today is a little bit about, kind of choosing the right provider and finding, a space where you feel really comfortable getting medical care. And then I'm also going to, a good amount of crossover with Dr. Stern, but there's some other kind of hot topic, controversies in specifically around, HIV and LGBT health that I think we should chat a little bit about today. So the metaphor that I use a lot with my patients in terms of finding the right provider is, we don't typically wind up settling down with the first person we go on a date with. We wind up, shopping around a little bit. You probably went on a handful of dates if you wound up, settling down with somebody. I really encourage people to feel the same way in terms of picking a primary care with that. if just because your insurance assigned you to see somebody or just because you got an appointment with a certain person at a health center or at a practice, that doesn't necessarily mean that that person needs to be your provider. If for any reason you don't feel comfortable, you should switch. And you should keep switching until you find the person that you feel safe with. There's a lot of things that go into, am I talking too loud? Okay. There's a lot of things that can kind of, that can be a part of the consideration in terms of barriers between a primary care and a patient. Some people can have issues around trust if it's not the right fit. Some, historically, a lot of populations also feel general distrust with, with medical providers. There can also be, especially with long-term relationships, if you've been with somebody, if somebody's been your primary for 10, 20 years, there can actually be feelings of disappointment that play into it. The expectation that, because somebody prescribed you a medication or talked to you about, dietary changes after you get a diabetes diagnosis. If you don't do those things, some people are reluctant to talk to their providers about that. I really, really encourage you to, go ahead and disappoint a little bit. I mean, it's not really doing anybody any favors if you're not opening the door to honest communication. Particularly around HIV, it becomes a bigger issue. If you're having trouble taking a pill every single day, if you're having side effects, if you're having diarrhea and you don't really feel like talking to somebody about that, there are always ways that we can simplify regimens, we can change your medications, we can stop side effects. But again, that requires you to really kind of put it all out there with somebody and say, I'm having diarrhea every single day. Can we do something about this? I see a lot of issues around discussing sex, and that's something that I'm going to talk about for a little bit, because sex is something that we all love having, and we also all love not talking about. So, sex is. You have to be able to tell your provider what kind of sex you're having, what questions you have around it. And I mean the specifics. This is historically something that, socially we haven't really talked about. We tend to get a quick birds and the bees conversation with our parents at some point, and then from there you're kind of on your own. Maybe you talk to some of your friends about it. But, there isn't just one kind of sex. The sex we have changes over the course of our lives. And particularly when we're talking about, aging populations, I think that there's a societal expectation that people, that older populations aren't having sex, and of course we all know that that's not true. The language that you use with your provider is something that, I want you to feel comfortable saying, it's our job as your medical providers to know what you're talking about. So, my approach with patients is I typically say, just spit it out. Say what's going on. Tell me, in your own words, what's happening with, what concerns you have, what kind of sex you're having. Dr. Stern talked a lot about STDs. STD screening is something that, basically for the entire time that you're having sex, especially, for folks who are in, non-monogamous relationships or have multiple partners, STD screening should be a kind of constant part of primary care. STD screening completely changes depending on the sex that you're having. If you're only having oral sex, we need to be doing gonorrhea and chlamydia testing in your throat. If you're only having, vaginal sex, then we need to be testing your urine. So, it really requires people to, kind of do a little dirty talk with your providers, and I really encourage people to do that. There is a reluctance for some providers to offer STD screening. I don't know why this is. I think that, we, in our own respects probably are not as comfortable talking about sex as we should be. So if you're having sex and you think that you should be getting tested, I kind of put it on, y'all, you should be asking for this. And if they're not offering it, then maybe you're not at the right provider. There's a lot of kind of downstream feelings that I have about being comfortable talking about sex. So if you're comfortable talking to your provider about the sex that you're having, you're going to be a little bit more comfortable talking to your partners. And communication around sex is something where we wind up, you know, it's how we have more satisfying sex. It's also how we have safer sex. So, you know, open the doors as much as you can. And if for any reason, again, if you feel like you're not comfortable having that conversation with your provider, then, you know, maybe it's time to have that conversation with somebody else. The next point that I wanted to talk about is PrEP. Of course, we've already talked about PrEP. It's something that that you kind of, you know, like at least in the LGBT community and the, you know, the HIV community, you can't really escape, you know, articles or, you know, publications about PrEP right now. You know, again, it's, you know, it's taking a medication that we've historically used, a backbone therapy for HIV, and dosing it, you know, at least as FDA is approved every single day to prevent somebody from getting HIV. We know that it's, you know, we know that it's incredibly effective when you take it. Much like HIV medications, they only work if you take them. But I've seen again, you know, kind of going back to the point about communication, I've seen a lot of cultural shift over the past few years around PrEP in terms of education to the community. I mean, it has become kind of a grassroots topic. You know, people are talking about it. Friends are educating each other. So I have these, you know, 19, 20-year-old kids coming into my practice who are coming in asking about going on PrEP, talking about the risks that they're having, you know, and, you know, saying that, you know, well, I have 2 partners, one of them's positive, but his viral load's undetectable. And I mean, the sheer fact that a 20-year-old knows this language at this point is actually really impressive to me. So it's, I do think that there's a lot of benefit to it. Of course, there's controversy around it, you know. Are we promoting, you know, through using PrEP, are we promoting people to stop having safe sex? That's the big question, and that's what kind of scares everybody about using PrEP. There was a trial or a study that came out earlier this year, probably around September-ish, that followed people for 2.5 years in San Francisco. There were 600 HIV negative gay men. I think almost only gay men were in the study. And the trial concluded that there were 0 new HIV infections with PrEP as the intervention, which is incredible. That number is, you know, staggering. There was a major uptick in STDs. So there's a downside there, right? So the big question is, you know, were there more STDs because we're screening all of these people all of the time, or were there more STDs because people are having higher risk behaviors because they're taking PrEP? The numbers were, I think 30% of the people in the study had an STD by 6 months and 50% by 1 year, which is, you know, pretty high. About 41% of people in the study reported that they were using condoms less frequently because they were on PrEP. You know, there's a lot of, I have a lot of feelings about that. I think everybody has a lot of feelings about that, but either way, we know that from a harm reduction standpoint, if people, sorry, a little bit of a cold. If people, you know, aren't using condoms and instead are willing to take this, there's a massive benefit to this medication. A quick note about some, you know, advancements over the past few months with HIV medications. So the vast majority of people on HIV medications, part of the backbone of the medications that they're taking is a medication called tenofovir disoproxil, which is part of Truvada, and it's part of Atripla, it's part of Complera, it's part of Stribild. So it's a medication that very, very, very many people are already on and have been for years. The take-home point of the new version of tenofovir is that it acts more directly. The active medication goes kind of directly intracellular instead of being kind of wasted around the cells themselves. So the take-home point is that at a 1/10 of the same dose, we're able to achieve an equal, if not slightly better effect from the medication. It's a huge, huge advancement because, you know, not only are most people with HIV on this medication, but also everybody who is taking Truvada for PrEP is getting this, you know, is getting this medication that doesn't cause these issues typically right when you start taking it, but we see, you know, 5, 10 plus years down the road, we see these things start to develop. It's called tenofovir alafenamide, And currently it's only available in one form. Over the next year, every form of the medication is going to be updated. So we'll be able to switch everybody over to this, nicer, neater, and safer for long-term use, Historically, we were, the approach to HIV treatment was we get medications that will save people's lives because that was the initial goal. We save people's lives. We're now kind of, in a golden age where we're planning for the long term. I'm planning, who knows how long, until we have a cure, we're going to be probably treating people with tenofovir. And that population is going to continue to age, and things like kidney disorders and osteoporosis, we already know are going to be of higher likelihood in older populations. So this is a major, major advancement. So, if you have any questions about this, I would really strongly encourage you to ask your providers about that. So again, more crossover. I wanted to talk a little bit about hepatitis C. So again, historically has been something that we've seen disproportionately in IV drug users. Over the past, I'd say, decade or so, there's been a lot of really compelling data, specifically around gay men, and more specifically around HIV-positive gay men and hepatitis C transmission. So we know that our population, that population specifically, is at higher risk for getting hepatitis C from a sexual transmission standpoint. It's still kind of poorly understood, how or when this happens. We know contributing risk factors. So hep C is only spread through blood. So it's from one person's bloodstream to another person's bloodstream. So if we're talking about anal sex, we know that it's more likely, folks are more likely to have a small amount of blood present during anal sex than they are during oral sex. We know that if we're talking about vaginal sex, we know that if a woman is menstruating, there's obviously more likely blood present. So anytime that there's blood is really the question with hep C. Again, major, major advancements over the past few years. We're now able to cure, and we can safely use the word cure with hepatitis C. We're able to cure hepatitis C in approximately like 97% of patients that have the virus. It used to be an astronomically challenging treatment. It used to be a year of therapy that made people feel terrible, and we were able to cure about 30% of them. Those numbers are terrible. Now it's one pill a day for the most part. Most patients can be treated for 8 to 12 weeks with a 97-ish% cure rate. So that's been something that we've had some major, major leaps with. Again, Dr. Stern mentioned the big controversy about hepatitis C treatment is the cost of it. That one pill a day for 12 weeks regimen retail cost is about $94,000. Obviously, your insurance company doesn't want anybody to cost $94,000. Especially if you're on Medicaid. There have been a lot of issues around Medicaid coverage of hep C treatment. One benefit, at least for Philadelphia residents, at least in my practice, Keystone Mercy is the primary Medicaid that my patients have. And if somebody is co-infected, so if they have hepatitis C and HIV, with the right amount of legwork, Keystone Mercy will now cover this medication. So there's a little bit. It doesn't matter how far along they are on the fibrosis from a scarring standpoint. But yeah, there are still a lot of insurance companies that basically only want to pay for the medication when somebody is essentially coming close to becoming very sick or dying from the hepatitis C. So to be continued. Hopefully prices drop and insurance companies get with kind of the moral decision. But for the time being, it's still kind of a tricky issue. Of course, the presence of, just jumping back to transmission, blood being present, the presence of another STD increases the risk with anal sex of hep C transmission. So does the presence of, a wart. So this is even more reason that you should be, getting regular, if you're having anal sex, you should be getting regular, anal exams during your medical appointments. Similarly, something that people tend to forget a lot about is that there's more likely to be blood present if you have hemorrhoids, or if you have a history of hemorrhoids and you have a hemorrhoidal skin tag or whatever. So again, just making sure you're talking to your providers about, you have to tell me if you're having anal sex, you have to talk about your butt. There's no two ways around it. You know, it's got to be an open communication. One final point about hepatitis C is that just because we're able to cure it doesn't mean that you can't get it again. And one huge issue in terms of getting your insurance company to pay for a $100,000 medication is you can be really, really sure they're not going to pay for it a second time. So there is a lot of education that needs to go, you know. So of course, you know, we can easily talk to people about how to prevent Hep C infection from a needle standpoint, you know, using needle exchanges or, you know, helping folks get into, you know, into methadone or Suboxone programs to get off of drugs. We can't tell people to stop having sex because that's not realistic. So it is, again, going back to education, it's going back to screening. It's going back to, you know, talking to your partners about, you know, not just their, you know, the last time they had an STD screening, the last time, you know, what their HIV status is, but also if they've been screened for hepatitis C. Final population that I wanted to talk a little bit about, and I think I see a little bit more frequently than a lot of other folks is the point of crystal meth in our community. So crystal meth has become, you know, it's kind of been referred to as the second epidemic, specifically referring to the frequency with which we're seeing crystal meth addiction in our HIV positive population. So this is regardless of age, and that's something that, you know, that I you know, heard initially when I got into practice, and I'm consistently surprised by. So I am seeing, you know, a large number of my, you know, recent HIV diagnoses in my practice have been people over the age of 50. So, you know, this is absolutely something we are seeing more HIV in the aging population who have not historically been HIV positive. And the one, you know, of course, there's the issue of condom fatigue. You know, after 30, 40 years of wearing condoms all the time, you know, people are just kind of tired of it. But secondary to that, there is, you know, the crystal meth epidemic in our community is something that we know that when people use crystal meth, they have very uninhibited behaviors. They're not, you know, it is kind of a, you know, it is a drug that's closely tied in with sex, and people are not using condoms with sex. So it is a continuing trend that I've seen in all of my 50 plus recent diagnoses. They have been using crystal meth. So, you know, what is it about this drug? Of course, there's the sexual piece of it. There's also escapism and depression. You know, why do we all turn to substances from time to time, you know, to get away from our regular life stresses? But the population that, you know, specifically is at, you know, a very, very high likelihood to be, you know, kind of fall into, you know, crystal meth problems is folks that are already HIV positive. There was something like 60 to 75% of people who go into crystal meth treatment, you know, go into a treatment facility to get off of, to stop using crystal meth, are already HIV positive. We know that, we know obviously all drugs are bad for us, right? Everything that's fun in life is bad for you to a certain degree. But the thing about crystal meth that is so detrimental, you know, Dr. Stern talked a lot about cardiovascular disease and its association with both aging and with HIV. Crystal meth really amplifies that. It's a very, very strong stimulant. Similarly, it also chemically interacts with a handful of HIV medications. So our patients who are taking, you know, HIV protease inhibitors or have any sort of a booster on board, they actually, that can amplify the crystal meth effect. You know, personally, you know, I've worked with addiction for the entirety of my career. I worked in social services before I got into medicine. So I honestly, like, you know, kind of speaking off the cuff, I have never seen a drug that's been more detrimental than this drug. I've never seen something that has been more destructive or harder to stop using. So again, you know, much like all other substances and much like sex, this is something that, you know, if somebody, you know, if you have a problem with this, if, you know, even if you have any questions around this, please, please, please talk to your providers about it, because the worst thing that you could possibly do is just assume you know something and, not ask the proper questions.
So what's going to happen now is we're going to bring all of our panelists back up to the front here and open it up for questions. We do want to also have the option, if anyone has questions but isn't comfortable standing and addressing them to the entire room. Joe Potter, who is our intern from Temple University, is coming around with some note cards and some pens. So if anyone's more comfortable just writing down their question, we'll collect those and be able to read those to the panel. Going to bring Mark from the Colors organization up for a moment, just to talk a little bit about Colors and the work they're doing, as well as all of the great resources that they have in the back of the room. So I'll turn it over to you, Mark.
Okay, thank you. I'm going to get a little short and sweet. My name is Mark Wilson. I'm the Executive Director at the Colors Organization. And back at the table, we just have some resources. We do have a pamphlet on PrEP. So I believe one of the speakers, two of them spoke about PrEP. So there are some information about PrEP there, as well as some condoms, some lube, and some literatures about different programs and services that we offer. So if you have any questions for me, Will and myself will be back there. We'll stay throughout the duration of the event. Thank you.
Yes, Dave.
I'm just going to bring up the question of adherence. I know we have these packs on here, but we didn't really talk about it. So if someone could elaborate on what this is.
The pill box.
And how do we ask for this?
These pill boxes are being set up, and a lot of pharmacies are now starting this as a patient service because of adherence issues. Whether it's through an HIV medication, whether we use it quite a bit for a lot of our transplant patients, it's the fact that they can be on up to 17 different medications a day. These pill boxes, if you want to hold it up for a second and just show everybody around, so you guys can play around with these. I believe that they're being supplied by Walgreens. There's actually candy. So play around with them. Pharmacists can actually fill these up so that you have a week's supply of medications. And if you're taking multiple medications on a daily basis, or even at breakfast, lunch, and dinner, we can supply them so that everything is in there for you as one full dose. So you don't have to go through 5 different bottles to take your different medications. You don't have to get 3 different bottles. You can just take it from there. Not all pharmacies will do this, but specialty pharmacies, Walgreens does it. I know that CVS will do it on a lot of their occasions, or they may have to send out, but they will certainly get them done for you. And most mail order pharmacies now have this service as well. The other thing is, I'm talking about compliance. In the back, I've gotten some pill boxes as well for people. Big thing here is that with compliance, it is, and I'm sure my compatriots on the other side will agree, is that these meds only work if you take them. And a lot of the medications that are being developed right now are extended release products. So when zidovudine or AZT, which was the first medication that came out for AIDS, you had to take it 6 times a day, around the clock. Now you can get away with taking 1 tablet once a day. And this makes things a lot easier for patients, but in certain instances, you're going to have to take these meds 2 or 3 times a day. That compliance issue there becomes now onto the patient, and really makes it much more difficult in therapy, because to be quite honest, in a lot of our busy schedules here, I don't know if I can remember to take a medication 3 times a day. It makes it much more, but these pill packs really do help a lot of that, because it's set up especially for our geriatric population, our populations who may have some sort of Alzheimer's and some sort of dementia where there are other caretakers involved. This helps tremendously in those type of situations. And they're now working with these as well, so that the labeling inside will actually include all the medications that is on, so that if you do need to go to a hospital or you do need to go someplace, all that information will be there.
Told once by a nurse who was coming to the house that I do not put my HIV meds into a pill box to keep them in the original container.
It's not true.
I just wanted to clarify, because I heard both sides.
I would tend to think that almost any med is, if you're using those pill boxes and you're taking them out for 7 days, it's not. If they're going to be out in air and open exposure for months at a time, there could be some problem with that. But taking them out of a regular container, putting them into a pill box, there should be no problem with that.
That may have been Norvir when it used to have to be refrigerated.
Rated.
I have the shingle vaccination. Seniors should get that. I have questions about the hepatitis vaccinations, and also vitamin D.
And
That's 3.
so the question,
Should we all have shingle?
everybody over 60 should get it. Actually, everybody over 50, but Merck can't manufacture enough to supply the country, so they sort of compromised and said 60. Insurance will pay for it the day you're 60.
And you also mentioned Hep C and Hep A.
Well, hepatitis A is a sexually transmitted disease. It's higher it's prevalent, endemic actually in the developing world. In this country, it's fairly infrequent. It'll kill somewhere about 1 in 10,000, so it's not a huge killer. It'll certainly make you sick. And men who have sex with men are the risk population who should be immunized.
And lastly, vitamin D.
Right. Anybody who's on a tenofovir or this new tenofovir, alafenamide, TAF, should be on it. And tenofovir is, as Dusty said, is basically in every drug everyone's taking. So to keep it simple, everybody should take vitamin D and calcium. And the simplest way to do it is Ascal-D. Ascal-D.
Oscal.
OSCAL, and then that big letter D. Other thing is for those is that you'll see that with is anyone who is on a drug that is being used for ulcers, so Zantac, ranitidine, things along that side, long term can cause osteoporosis as well.
And is 2,000, I think 2,000 milligrams
Units.
units, 2,000 units is the standard unit for vitamin D. Is that?
Vitamin D comes as low as 400 units, goes up to 10,000 units. So about 1,000, between 400 and 1,000 would be fine.
No one really knows.
Yeah.
No, like that.
I'm on an osteoporosis regimen, so I take like 1,200 calcium that comes with the vitamin D, but then I take extra vitamin D plus vitamin K, which inhibits somehow the calcium works also in the case with the vitamin K somehow counteracts that. I'm not really sure what that's about. That's not what I do. So that's what I'm doing.
Is it working?
I'm still here.
Then it's working.
Well, first I'd like to say, well, the information from the three of you was very valuable, and I appreciate the clear English, which is different from what we get on the little, what comes with our meds. I live up this end of town, and I get my meds from the Walgreens right on the corner. I walk in there and they know me, and I go to the office in Mount Airy, where when you go to see any of the 5 or 6 doctors, they say, the person takes you back and they say, are you still on these medications? Before you even see your doc. But one question for the gentleman in the middle. Sometimes when I get a renewal for one of my meds, or take, between insurance and income, I think all mine are generic, but sometimes I say, could you put the name of what the name of the medicine is? I'll sometimes say, I need this generic one, and you can't even pronounce the name of it. I said, could you put that on there? And sometimes they do, and sometimes they don't. But they always remember to give me the type of bottle that I can open, thankfully.
Well, depending on the medication that they're giving you.
Right.
If they're giving you a generic ibuprofen.
No,
but I'm just saying,
Okay, go
from an example.
Right.
If it's a generic ibuprofen, they cannot legally put the word Motrin on there because that's now misbranding it. That's actually a federal offense for doing that. You could lose our licenses for that. So they really can't. They may be able to put down generic for Motrin on there, but they can't just put down the word Motrin because that's now mislabeling a medication.
And I wanted to think briefly, I certainly believe that we should carry around a list of our meds and conditions. But in my apartment building, there's been at least 3 emergencies. And please recommend put the list on your refrigerator. And that's where they should look. That's their recommendation also.
One quick tip that I actually, for my patients who are on a handful of medications, particularly for folks who have some confusion around what medication is for which, I'd encourage you to talk to your providers. The way that we write the prescription is what shows up on the bottle. So if in that scenario, what I would write on your label would be, whatever your blood pressure medication is, take one of these once a day for high blood pressure, and they will print that on the label at the pharmacy. That just kind of keeps things a little bit more clear for folks.
Want to get one question that came in from the audience, but if you guys could talk a little bit about herpes and how herpes enter into the discussion, either if we are seeing increases in those preventative measures, anything along those lines.
So herpes is kind of a tricky virus. It's something that, for a lot of people, for the majority of people who get herpes, it's something that they have one severe outbreak, a primary outbreak, and then may or may not have kind of secondary, easier outbreaks, easier to manage rather. For people that have kind of chronic outbreaks, we can put them on a medication that will suppress that virus from replicating and thus stop them from having outbreaks. We know that folks who are HIV positive, just because immune function becomes a little bit more complicated, are more likely to require daily suppressive therapy. Of course, as you can imagine, the presence of herpes, makes it very easy to transmit other things, including HIV and hepatitis C and other STDs, because of the fact that there's open skin when somebody's having an outbreak. So the short answer to that is it depends on the individual and the way that, the majority of us, if you've had sex with more than one person, which, most of us, the likelihood of you having been exposed to yourself, I will. But the likelihood of you having been exposed to that virus at some point in your life is astronomically high. It's, I think the guess is somewhere around like 80+%. But of that population, only a small number of them will ever have symptoms. So the way that we test for herpes is we wait to see if you have an outbreak.
Can I just add a couple things? I think the numbers are, if you're African American, 60% of the population is positive. If you're white, it's about 30 to 40%. So it's basically ubiquitous. The only people that really have problems with herpes are people with advanced HIV that are not in care. And they will get horrible ulcerative disease on their rear end, particularly, or labia. But once somebody's HIV is under control, the herpes sort of goes back to what otherwise healthy people have, which is a periodic outbreak. If you miss a night of sleep, you get a cold, which is why it's called a cold sore, because it really pops out when you have another illness at the same time that suppresses your immunity. I'm not big on giving much in the way of therapy except for periodic outbreaks, and even for periodic outbreaks, the data is pretty clear that it doesn't really change the natural history of the disease much. So to me, it's a tempest in a teapot, except for its potential for transmission of disease, as Dusty's saying.
So a lot of the discussion today has been around men who have sex with men. Is there anything in particular with regards to injection drug use, heterosexual transmission with women that would require additional information or indications? I know you said top and bottom. Can you assume that if you're saying you're a bottom, that would automatically apply to a woman who is engaging in heterosexual or opposite sex?
I'm happy to give that question a stab. The heterosexual transmission in this country is primarily in women who are having sex with bisexual men who either haven't been frank about it with their partner and they don't use condoms, or women who are having sex with IV drug users who may know it or not know it and not appreciate that it's a risk factor for HIV transmission. The problem is that in those populations, the communication is lacking, and it's very difficult to prevent transmission unless women choose to be very careful, which is often a challenge. And if you look at the statistics, the heterosexual transmission in this country in women is primarily in African American women. It's wildly disproportional and unfortunate, but I'm not sure I have the answer for how we can prevent it other than by addressing all the social issues which are beyond my pay grade.
Actually, the other part that goes along with that is, and this is what I see much more in my practice, is that working in a labor and delivery unit and a gynecologic unit, I see women who've already been infected, who are now, we now have to worry about not only about the mother, but we have to worry about the unborn child as well. So there's a lot of specific regimens that are now being utilized for pregnant women, and you counsel them on whether they want to keep on their drugs depending on their CDC load and everything before or during pregnancy. But certainly during the delivery process, we have specific recommendations on how to treat that woman during delivery to reduce the risk to the unborn child. And then there's a number of specific indications to the now newly born child on what we do to prevent or reduce that risk of transmission as well. Because obviously the child, once they're born, they're carrying mom's antibodies for at least 6 to 8 weeks and up to a year. So we need to make sure that that child's being treated so that they are not being exposed or being infected after they've been born.
And just one bit of positive news is that there are about 125 pregnant moms delivering babies a year in Philly, and there have essentially been 0 vertical transmissions in the last several years. So even if the mom isn't on meds at delivery, if you give her AZT as she delivers and gives the baby meds for a number of weeks post, we've brought it to 0. So there's some good news.
I just have one more question. This is more for Wayne and the whole panel. But, so if you've mentioned people who take 16 pills a day. It seems as if generic pills are small, bright, white, round pills, which makes it difficult if you're taking 16 small, white, round pills a day. Is there anything that can be done from a consumer advocacy standpoint to try to get manufacturers of generic drugs to put some color into them so that they are uniquely identified?
Good luck. That's my thought.
I think that there's been lots of talk about this. There's a whole group that's actually just right outside the city in Conshohocken. It's called the Institute for Safe Medication Practices, which is run by a team of pharmacists, nurses, and physicians that take a look into these type of things. But the problem that you have with generic medications is the fact that companies buy and sell each other out. So there's not a uniform process to say that all antihypertensives have to be white, all anxiolytics have to be green, and all antidepressants have to be purple. There's nothing in the ruling about them. And quite honestly, I can't see any law taking effect which would be able to differentiate, because the only way that you can differentiate right now, and this is by law, is that all pills have to have some sort of identification labeling on them. And we have computer programs which I can say, okay, I've got a white pill, it's scored, there's 325 on one side, there's endo on the other. I can tell you exactly what that is, but I don't think we have the authority or the resources right now to say, okay, well, for the tens of thousands of different drugs out there, we can't make every one of them look different. And as new drugs are coming out, let's say, let's put it for an old drug, let's say like Valium. We've all been told that diazepam for Valium, the yellows are the 2 milligrams, the blues are the 5 milligrams, the greens are the 10 milligrams. Manufacturers have now, the generics have put those through, but the big thing is that all the generics look the same with them, but if you want to take the real non-generic Valium, that company has put a V into it. And I think that you're going to be seeing with a lot of these other drugs that are coming out, and Dusty referred to this, new drugs coming out in the market, is that, let's say with Arvoni and some of these other Hep C drugs, is that they're making a lot of money right now. I mean, $1,000 a day for a tablet is ridiculous, where it's only costing them literally pennies to make it. But you're going to find out as soon as this patent runs out, they're going to come out with a bit of a different formulation, just like with the tenofovir, is saying that this is safer, this is much more effective, and they're going to be able to keep those patents up with that money running that way. So I had a question in the back.
How long is the way out the last drink before
Yeah, that's actually easy. Alcohol is cleared by the liver, a healthy liver, at 1 ounce per hour. So it's pretty gone pretty quick. But what I've had problems with is not booze, but pot. And pot, if you smoke a pile of it, will stay in your system for weeks and weeks. And if you take ibuprofen, you'll get a false urine drug screen sometimes for pot. And you get yourself really in a tizzy. I've got patients who say, come on, doc, I don't smoke pot. And they don't. That's much more of an issue. And obviously they're looking for any reason they can to deny coverage. And in fairness to the insurance company, what happens is they set their premiums in the fall to come out January 1st. Then all of a sudden you add several $1 billion of expenses to their insured population. They're not sure how they're going to cover their bill when they've already sorted out their cash flow for the year based on premiums. So it's going to take another year before they're going to be willing to take on these new drugs. Obviously they predict and build in. But not that I'm a friend of the insurance company, I'm not, nor the drug company. But they have a legitimate issue, actually, in trying to slow down the cost of meds. Too bad that they don't work with the government.
Just one other point. There has been, so going on guidelines, we, as treaters, I personally never thought that abstinence was required to treat somebody for hepatitis C. And the guidelines certainly don't say that anymore, and insurance companies have been slowly, but recently following suit. So I know I mentioned before about, Medicaid's now covering co-infected patients. They also have dropped their drug and alcohol abstinence requirement.
Really?
Yeah, you don't have to put a UDS or an alcohol on.
And just one other thing, if we're talking about pot, it does clear much more slowly from the system, but you could be off it for years. And this is one of those drugs we call it's fat soluble, so it is sort of actually in the fat of your body.
Is that why I keep testing positive?
So if you decide that you're now feeling better about yourself, you've not smoked pot for 10 years, you're obese, you now start losing weight, you can turn positive again because you're now releasing it.
My days in the 70s, huh?
Okay. If you smoked pot a number of years ago and were especially obese at that point in time, even though you've not smoked, pot or the THC component can be stored in the fat of your body, and as you lose weight, your body is now releasing it again. So even though you've not smoked it, you can actually test positive. And if at that point in time, what you want to do is you want to do not only a qualitative, but a quantitative as well, because that'll make up the difference.
My question is for Wayne, and that is, if you're HIV positive and your partner's HIV negative and you want him to get the PrEP medication, is he the one that goes to the doctor to get it? Okay.
Yes.
Yes.
Yeah, absolutely.
I just wanted to make sure.
Insurance will pay for it, too.
Even Medicaid.
All right, thanks.
The question was whether, you know, if in a couple where one partner is positive and one is negative, it's the, you know, it's on the negative person to go seek medical care to get onto PrEP.
And the only reason not to take it is if you have kidney disease. That's it. Otherwise, you're good to go.
Thank you.
I'm George Starr. I appreciate the friendliness that we never be disclosure and stuff. I also really appreciate you brought up some of the anyone.
I'm sorry, we're having hard difficulty hearing you.
I'm sorry, I was unable to hear what you said.
Okay, so I tried before the negative, I tried something that, and it was 1 month, and it did 3 months, down to the beginning, to 5 years off that, but it was difficult things that I did. One thing that's not spoken about more from both the practitioner side and the community. And lastly, you know, pretty sure, my doctor would try, only symptoms I have are residual anxiety. You may give up there.
So the question was, why do we think that more people aren't talking about crystal meth, and then separately Lyrica?
Not giving that advice, but my doctor didn't know about it.
I think that it is, so crystal meth is something that disproportionately affects, the LGBT population. And I think that if you have a medical provider who doesn't specialize in working with that community, I think that the likelihood is that person is going to be a little less well versed in terms of, dealing with the addiction to crystal meth, and also the ways that we can help support people get off of it. So yeah, I absolutely, again, would encourage people to seek the medical care as best they can. You can't always find the perfect person for every issue, but find somebody who's comfortable treating whatever it is that you're looking for. And separately, yeah, we do know there are some chronic long-term issues in terms of coming off of crystal meth. We do see, of course, they tend to be, of course, the physical stuff, in terms of, dealing with, ramifications of if there is any cardiovascular disease that develops. But more specifically, what I see is the mental health stuff. So is anxiety, depression, and psychosis. Some people have kind of frank psychosis coming off of crystal meth, and they actually have, can have 6 months to a year of delusions or hallucinations. And, the way that we manage all of those, whether they are, and it can sometimes, not so much with the psychosis, but anxiety, depression, is it a chicken or the egg, Did the person wind up, kind of turning to a substance because there was depression or anxiety, or did those things result from being on the substance? It doesn't actually make too much of a difference because we treat it the same either way. And yeah, using Lyrica, you specifically said, not obviously something that is an initial go-to for anxiety, but we have used the similar drug, gabapentin or Neurontin, has been an off-label use for anxiety for decades. So I could only imagine that the pregabalin would be similar.
Someone have a question over here?
I was just going to ask, it's a pretty simple question. Is the prevalence of HIV high, or have you guys seen it in the lesbian community?
No.
I mean, I'm sure it's
there.
Yeah.
I mean, it
I just didn't know if it's significant like it is in the gay male.
No.
When I was working for the AIDS task force, we used to say that lesbians was the lowest group, and that was actually God's gift to them because of the fact that we weren't seeing AIDS in that population, where we were seeing it in many others.
So I just want another audience question. You talk a little bit about some of the common comorbidities, multimorbidities. So someone who has more than 2 or more chronic illnesses. So both what are some of the common ones that we're seeing, as well as kind of how to bring that up with healthcare providers.
I'll give it a try. The common comorbidities that I see in my aging population: coronary disease, hypertension, diabetes, high cholesterol. The trifecta, it's ubiquitous. Everybody's got a few of them. Certainly HIV drives them, and in our office we're all over these problems. But I don't think that they're enormously overrepresented in HIV populations. I think that they're part of the aging process in general, and we're sensitive to it. And in an ironic fashion, I actually think my HIV patients get better care than some of my HIV negative people who come and see me every couple of years when they remember to come and see me, while my HIV positive people come and see me every 3 to 6 months, and they get really excellent internal medicine care because the HIV is the excuse to come to the office, and it's like, fine, your numbers are great, now let's get into all these other issues.
And the thing that I would go along with that once the diagnoses have been made, there's usually a medication that goes along with each one of them. So then on our standpoint, that we were looking at drug interactions and making sure that people can be compliant as much as possible.
I like what you said about when your patients come to see you every 3 months, but in the new healthcare system, I had a specialist, I still do, but I can't see my specialist without a referral from a primary. And just like the other doctor said, there's nothing wrong with that going around until you find someone that you're comfortable with, but I need to start with one just to get a referral to go back to my specialist, and then if it's not someone that I like, and I have to, do that merry-go-round.
Well, a couple suggestions. I'm no insurance expert, but a lot of the carriers will, once you find a doc, an HIV provider, PA or MD that you like, you can get generally a referral for 3 visits. So that usually will take you out for a year, roughly.
From whom?
From your primary doc, you can get a referral that's good for 3 visits to an HIV provider. So once you found somebody you like, and there's plenty of good people in the city. There's not millions, but there's certainly a few dozen really terrific people in the city that do what we do, that Dusty and I do, and you'll find somebody you like.
I need one primary to start.
You need a primary that's generous enough to say, this isn't my area, that person's better than me at this. So you've just got to get somebody who's frankly humble enough to say, I can't manage this, get help.
Sorry to jump in on this, but the other thing that you could do is there are a few options in the city specifically where you can get primary / HIV care. So you can have a primary care provider that manages that specialty also. So it just takes the, doing a little bit of research. There are a few options where, where you could get that, you could get whatever care you wanted, in the same place where your primary care is by your primary care, and not have to go to a specialist.
I already have a specialist, but I can't get back to my specialist without primary referral.
Correct, yeah.
What I'm saying, I want the name of the primary I can go to.
So,
And even in my insurance company, they have doctors listed and it's supposed to have some kind of ratings or referral information next to their names, and every name is blank. It's like they don't give you that information that makes you think, okay, maybe I'll try this person.
So I just want to say that, so if you wanted, so if you have a primary care, you know, so that's the first thing you need to do, is a primary care doc. And probably if you talk to people, your friends, or there's probably a way that you can find primary care docs in your healthcare
understand that, and I'm not trying to get one to treat both. I'm just trying to get one primary to get back to my specialist.
I think he's looking for a recommendation for a name.
So perhaps after the program, perhaps some people on the would be able to give you some specific referrals. You could definitely go through the organization route in town, seeing who the referrals could be there.
Sorry to jump on that. Yes, absolutely. But both Billy Fight and Mazzoni are, our HIV specialists too. So we typically do all of our own. I know Fight only, we have a few patients at Mazzoni that we refer out for HIV care, but everybody else we just treat ourselves. And I know Fight does all of their own treatment.
All right, so I'm gonna try to wrap things up here, but again, our panelists will be around for a couple minutes after the program if there are any questions that you wanna follow up with them on a one-on-one basis. But again, we'd like to give big thanks to John Stern, Jim Markart, for sharing their Saturday with us and providing us with this wealth of information. A few other notes. So in the folders that you got when you came in, there is an evaluation form. Really, really appreciate them to just take a minute or two and fill out those forms. This helps us know how we are doing as an organization, what went well with the program, more importantly, what suggestions you have for how to make our programs better, and more topics that we can cover. As I mentioned at the beginning, we're debuting this as a series. So there's going to be a lot more programming coming in the next couple of months around anything from emotional health, emotional wellness, ways to keep from becoming isolated, ways to navigate relationships, whether they be romantic or sexual, and a whole range of issues. And we really want to get input from the community on what those are going to be. We'd also like to just recognize Dave Gianna over here, give a wave. As well as Heshi Zinman over here, who are both members of our Community Advisory Committee who've been helping to put this program together as well as starting to plan these ones in the future. And so do you just want to say that that is an open invitation to anyone here if you would like to be a part of this process in helping us come up with the programs that we're going to be offering in the spring and in the summer, to talk to one of us. We can definitely get you involved. We're really looking to grow this committee and have more help in putting these together and reaching the community. That all being said, I want to thank you all again very much for taking time out of your weekend to spend with us. Please take some time. Absolutely. Please do take some time to look over the resources in the back of the room, both from Colors, as well as some of the resources we have on the table as well, and help yourself to some lunch. We have this room for a little bit. So grab some lunch, sit, get to know the other people in the room here, and we look forward to seeing you again in the future.